remains the second most common cause of dysautonomia, what everyone needs to know. I'm Jennifer Sam Gabati. I'm a nurse practitioner and patient advisory chair for Dysautonomia International. I'm also a patient both with Sjogren's and dysautonomia. Tonight, I'd like to introduce Lauren Stiles and Dr. Sarah Schaefer. We're going to be doing a slide presentation, and then afterwards, we're going to be doing a Q&A. You can type in your questions. I'd like to introduce Lauren. Lauren is the founder and president of Dysautonomia International. She started the organization in 2012 after her own experience with Sjogren's associated dysautonomia. Lauren is also a research assistant professor of neurology at Stony Brook University, where she focuses on POTS and long COVID research. Welcome, Lauren. Dr. Sarah Schaefer worked as a health physician in the San Francisco Bay Area for 18 years. Her career came to an abrupt halt when she experienced a severe worsening of what turned out to be undiagnosed Sjogren's disease and POTS. Her difficult experience with diagnosis inspired her to create the website Sjogren's Advocate. Sjogren's Advocate provides tools and strategies that help patients achieve timely diagnosis and proper care for the systemic aspects of Sjogren's, including dysautonomia. Welcome.
Thank you so much, Jen, for hosting, and thank you for all the work that you do. So I'm going to jump in and do some slides, and then we're going to come back with the three of us and have a Q&A panel. For our guests who are tuning in, feel free to type into the Zoom Q&A any questions you have. We ask that your questions are not individual medical questions, like how much should my dose of Mestinon be, or how, very specific personal things. Try to keep them broadly applicable, and we're more likely to be able to get to them. We usually have more questions than we can answer in the time allotted, but we will do our best. So please be patient with us. All right, so I'm going to kick off the slides right now. Let me just share my screen. And so my purpose in this talk is not to be the definitive everything you need to know about how to diagnose and treat and manage Sjogren's. I really wanted to emphasize what we know about Sjogren's and dysautonomia, what we don't know, and the importance of getting diagnosed with Sjogren's if you do think you have this condition, because it can really, really change the long-term outcome of your dysautonomia and other manifestations of Sjogren's that you might be experiencing. So this is the official title of the lecture. But what I also sort of jokingly refer to my Sjogren's lectures, Sjogren's plus dysautonomia, because having one diagnosis no one can pronounce wasn't hard enough. So if you are unlucky enough to have both of these, you get to spend a lot of time spelling your diagnoses for when you have new doctors or you're in the emergency room. So just a brief overview, because I know that we have different listeners from different communities, and maybe not everyone knows what dysautonomia is. A super simple way of thinking of it. Dysautonomia is any clinically significant dysfunction of the autonomic nervous system. And I will jump into what that is. What is the autonomic nervous system? What does it do in a bit? But there's two different types of autonomic dysfunction, one way to classify them. There is a structural autonomic dysfunction, where there is an actual damage or loss of autonomic nerve fibers so that they can't communicate properly with each other because there is a structural change. And then there's functional changes in the autonomic nervous system. And I know when patients hear that word, they get very suspicious, because a lot of doctors use this term functional as sort of a euphemism for it's all in your head, it's not real. And so when I say the word functional, I do not mean that at all. I mean in the most literal sense that your nerve fibers are still intact, but something is making them not function properly, like an antibody that might be in the way of the neural receptor, neurotransmitter problems with your catecholamines, etc. So that is not at all in your head, but it is something where your nerves might still be intact, but they're not working the way that they should. So both of these types of dysautonomia are often present in Sjogren's, and in general, in the dysautonomia population, people often have both of these situations happening at once. So what does the autonomic nervous system regulate? Well, the easy answer is it regulates everything. It's the major communication channel between your brain and all of your organs and your homeostatic systems that keep your body in balance. So for the purposes of Sjogren's, it's really important to understand that the autonomic nervous system regulates tear production, saliva production, all of the exocrine glands, and those are the glands that produce moisture and sort of mucosal protection throughout your body. The autonomic nervous system also plays a huge role in regulating your immune system function. And that can be in a good way and in a bad way, depending on if it's imbalanced or if it's kind of gone askew, as it has in most people with Sjogren's. Well, all people with Sjogren's, but many people with dysautonomia who don't have Sjogren's also have some immune system dysregulation. And then for those of you who are part of the Sjogren's and dysautonomia community already, you often hear about Ehlers-Danlos syndrome and joint hypermobility. And I think it's also important to mention that the autonomic nervous system does play a role in connective tissue synthesis and repair. So I think when we're thinking about Sjogren's, sometimes doctors will refer to it as a connective tissue disorder, which it is, but it isn't necessarily always Ehlers-Danlos syndrome, but it can occur in people with Ehlers-Danlos syndrome. So this diagram is on the Dysautonomia International website, and if anyone would like to check it out a little bit more thoroughly. Let's see. So this is just another way of looking at the autonomic nervous system. I love this graphic because it shows you my favorite part of the autonomic nervous system, which is the yellow kind of bulbous, these are the sympathetic ganglia, sometimes called the sympathetic chain, and they're on both sides of your spinal cord. And they are sort of like little mini brains before a message gets to your spinal cord and up to your brain. It's sort of synthesizing information and deciding what gets through and what doesn't. And people who have Sjogren's can actually have a problem with their autonomic ganglia. And this is actually an area that is pretty much impossible to diagnose in a living patient really accurately, because we don't have any imaging technology that picks up the autonomic ganglia. You can't biopsy it in a living patient. And unfortunately, that technology doesn't exist, but that is something that Dysautonomia International has actually been advocating for, because it's something that would benefit a wide range of different autonomic disorders. Really, a lot of different diseases have autonomic ganglia problems. The green fiber here is actually the vagus nerve, and it's many, many, many branches. And so the vagus comes from Latin, meaning sort of like the wandering nerve. And that's why they call it the wandering nerve, because it really wanders throughout the body and to all of the organs. This is the parasympathetic nervous system. So what is Sjogren's? So, again, it's very complicated disease, but a simple explanation is that it's a systemic chronic autoimmune disease that is most commonly characterized by damage to the exocrine glands that produce the moisture throughout the body. But many organs and systems throughout the body can be impacted by the disease. It is not a disease of dry eyes and dry mouth. That is what a lot of doctors are taught about Sjogren's, because it's sort of the easy thing to remember. But it's really, really under recognizing the severity of the illness if you think of it as just dry eyes and dry mouth. There are an estimated 4 million Americans who have Sjogren's, and 75% are undiagnosed. Sjogren's occurs around the world. There's actually great research out of Asia, India, some studies in South America. It is definitely a global disease. There's no cure for Sjogren's at this time, but there are lots of different treatments aimed at mitigating the impact of the disease and improving the quality of life. And there is research underway looking to identify more effective treatments. So I would be, if you have Sjogren's, it is quite difficult to live with, but I would definitely remain hopeful and keep your ear to the ground to hear about, upcoming clinical trials and other research that you might be able to benefit from. So here is our common list of dysautonomia symptoms that are found across different autonomic disorders. So not everyone who has an autonomic nervous system disorder has every single symptom on this list. Some of us do, but not everyone, and these are just certainly not a complete list of symptoms that could be caused by autonomic nervous system problems, but these are sort of the primary symptoms that are often recognized. So if you took this list and you just crossed dysautonomia, these can also be symptoms of Sjogren's. And again, not everyone has every symptom, and not every Sjogren's patient has very obvious orthostatic problems and such. But I would actually, before I get to that, I just want to mention, there's a lot of other things that can happen in Sjogren's that we don't typically see in dysautonomia that isn't Sjogren's related. So people with Sjogren's get a ton of chronic sinus infections, nosebleeds, mouth sores, tooth decay, to the point where like you might have a 20-year-old who's had to have full tooth removal and dentures at 20 years old. Sometimes the tooth decay can be really aggressive and really rapidly happening because patients can get severe dry mouth. That is what leads to the tooth decay. People can have difficulty with chewing and swallowing, difficulty with their speech if they have severe dry mouth. There was a study showing that people with Sjogren's with severe dry mouth actually had really, really reduced quality of life due to the dry mouth, because it makes eating difficult, it makes talking difficult, it can cause a lot of pain. Some people with Sjogren's will get very swollen parotid glands. If you see someone who looks like they might have like bananas stuck to the side of their cheeks, they might have swollen parotid, which are the large salivary glands. Sjogren's can cause lots of pulmonary problems, recurrent bronchitis, interstitial lung disease, frequent pneumonia, difficulty getting rid of infections once you get a respiratory infection. And in part, that's because people with Sjogren's don't have the normal mucosal lining of their lungs. It's sort of like having dry lung, and that makes it harder to protect yourself against infections and harder to get rid of them once you do have them. So people with Sjogren's can also have really significant GI dysmotility, very often esophageal dysmotility, which is in part because some of the autonomic nerve receptors that are affected in Sjogren's also help control the esophagus. So people with Sjogren's often have abnormal liver function tests. They don't usually, it's not the most common thing to progress to severe liver damage, but sort of a lifetime of sort of chronic, low to mid-grade liver dysfunction can lead to some other problems, can make it difficult taking certain medications that need the liver to process. So definitely something to be aware of. Some patients do develop a chronic autoimmune hepatitis. There are other GI manifestations not on this list, but it's just sort of, one thing you'll notice is a lot of the things on this list have itis at the end of them, which is just Latin for inflammation. So I have Sjogren's, and I kind of jokingly call it the itis because it seems that it can cause inflammation in pretty much any organ or tissue in your body that it wants to. More systemic issues can be things like vasculitis, which is really your blood vessels having inflammation. You can get that in small vessels and medium vessels and large vessels. Some Sjogren's patients will develop lymphoma. People with Sjogren's have about a 40-fold increased risk of developing non-Hodgkin's lymphoma. And people with Sjogren's can have dermatitis and rashes. And sometimes in our dysautonomia community, we'll see a rash and say, oh, that's mast cell activation syndrome. But sometimes that is actually Sjogren's. And some of our Sjogren's experts, like Dr. Goodman at Mayo Clinic, who's a dysautonomia expert, will say, pretty much all of his Sjogren's dysautonomia patients have mast cell activation syndrome as one of their diagnoses. But when we treat the Sjogren's, the mast cell stuff often improves, not always, but often. Raynaud's, which is sort of another sort of vascular abnormality. So neurological symptoms of Sjogren's can impact any part of the nervous system. Obviously, if we're talking about dysautonomia, we're most interested in the autonomic nervous system stuff. But Sjogren's causes a lot of sensory neuropathies, as well as a sensory ganglionitis. The sensory ganglia are at the back of the spinal cord, sort of like those yellow nodules that I said were the autonomic ganglia. There are sensory ganglia in that area too. They're called dorsal root ganglia, and they can commonly be inflamed in Sjogren's, causing chronic neuropathic pain, which is pretty difficult to diagnose because we don't really have a good way of identifying a ganglia problem clinically right now. There was a research paper out of Johns Hopkins imaging, doing like very special MRI technique, showing that the sensory ganglia was inflamed in Sjogren's. And the ganglia that were inflamed corresponded to the region of neuropathic pain in the patients. And so when they gave these patients IVIG to treat the ganglia inflammation from the Sjogren's, the ganglia became less inflamed and the neuropathic pain improved. So I think that's, unfortunately, I didn't put that slide into this lecture. I think I could probably lecture for 5 days in a row on Sjogren's because I have it, and I've tried to really learn this inside and out, but I'm just trying to give you the broad overview to help people recognize how important it is to get diagnosed if you might have this. Musculoskeletal problems can be arthritis and muscle pain. Seems like just 2 little bullet points, but this can be truly, truly disabling if you have Sjogren's, any joint, any bone, any muscle. And sometimes it feels like all at once on fire. So that's really difficult. Ocular manifestations, people can get uveitis, scleritis, retinal vasculitis, which is the blood vessels of your retina getting inflamed, corneal inflammation and ulceration. And this can happen even when you don't have obvious dry eye. I can tell you my own story. I do not really feel dry eye. I don't ever say to my doctors like, dry eye is bothering me. I don't even use eye drops. But I recently went to get new glasses, and they were like, oh, you have corneal inflammation really bad in both eyes. And I was like, great. So that's the Sjogren's, but it was never something that I would have complained to my doctor as a symptom of, which is really emphasizes the importance of getting diagnosed and getting on preventative treatments to prevent these problems from developing down the road. So what percentage of Sjogren's patients have dysautonomia? So you could read different journal articles and they'll debate if it's 40% or 60% or whatever. I think that really depends on how you define what you mean by dysautonomia. So my answer is 100%, and I will tell you why. Because the dryness that is like the characteristic feature of Sjogren's that we sort of insist that all of these patients have before we diagnose them, whether that's right or wrong, that is what most doctors require before they'll even screen you for it, that you have dry eyes and or a dry mouth. That dryness is caused by an impairment of the autonomic nervous system. If you can see down here, we have the preganglionic parasympathetic nerve fibers, and they send a message to the ganglia, which then sends a message to these muscarinic 3 receptors, which are on the salivary glands and the lacriminal glands or the tear glands. And these receptors will, in Sjogren's patients, about 97% of Sjogren's patients, particularly early in the course of the disease, will have antibodies that block. This little X is representing an antibody that has blocked this receptor from getting this acetylcholine message. So when you have autonomic nervous system impairment due to the acetylcholine signal not getting through, that is a form of a functional dysautonomia. Even if these nerve fibers are fully intact and sending the messages they're supposed to, they can't get the message through to the gland because there's a blockage by this antibody on the muscarinic 3 receptor. So I would argue, studies have shown up to 97% of Sjogren's patients have these antibodies, and all Sjogren's patients have a problem with this signaling pathway. So I would say 100% have dysautonomia. Some doctors would say, well, blocking a muscarinic 3 receptor is not clinical dysautonomia. So that's up for debate. I think if you have a symptom like dryness, which we know happens in many autonomic disorders, that is a type of dysautonomia. So the dysautonomia in Sjogren's can range from very mild to severe. When I say mild, I don't want anyone to think I'm minimizing. I am a patient who has this. I don't think any of this is mild when you have to live with it. But if you just have the dryness and you don't have this sort of broader systemic dysautonomia, I would say that that's a mild dysautonomia in a Sjogren's patient, even if it doesn't feel mild. And that's incredibly common. That is pretty much everyone with Sjogren's. Then there's a subset of Sjogren's patients who have POTS or orthostatic intolerance, which I would say is a moderate dysautonomia. And again, if you're a POTS or an OI patient listening, you're probably pounding your fist on the desk at me right now saying, there's nothing moderate about this. It's terrible. I know this is the type of dysautonomia that I have. But in terms of the severity of how we would scale the worsening of dysautonomia, POTS and OI are sort of in the mid-range. And then the most severe forms of dysautonomia, which generally get lumped under autonomic failure, is the term a lot of doctors will use, neurogenic orthostatic hypotension, which is people who every single time they stand up, they have a dramatic drop in their blood pressure within 3 minutes. And it's because their sympathetic nervous system has basically stopped being able to send messages, which is really the opposite of POTS and OI, which is when your sympathetic nervous system is sending too much messages. So these patients, their heart rate can't even compensate by going faster because their autonomic nervous system is so severely damaged. A word of caution, a lot of orthostatic hypotension is caused by medications. So that's not the same thing as a dysautonomia orthostatic, like a neurological orthostatic hypotension is not the type that's caused by a medication because that's reversible. And people can also get orthostatic hypotension from just being very frail and deconditioned, which happens to some people with chronic illness if they've been so sick that they've been stuck in bed for a few months, or they've had a really dramatic weight loss. But that is different than the neurogenic orthostatic hypotension. And a good autonomic specialist can distinguish this and help people find whatever type it is, they can help figure it out. Esophageal dysmotility, that's really significant. It's preventing eating or preventing proper nutrition. Gastroparesis, which is sort of like a paralysis of the stomach. Anhidrosis, which means a lack of sweating. Bladder failure, which it can go in sort of both directions. Most people with bladder failure have difficulty releasing their bladder, so they have to use a self catheter sometimes to urinate. And then there's also autoimmune autonomic ganglionopathy, which is a specific type of autonomic failure that is associated with antibodies or other immune biomarkers that bind or impact the functioning of those autonomic ganglia we talked about before. And this can overlap with Sjogren's. So what percentage of dysautonomia, if I think 100% of Sjogren's patients have some form of dysautonomia, what percentage of dysautonomia patients have Sjogren's? And the honest answer is we don't know. Sjogren's is only one type, one underlying cause of dysautonomia. There are many, many different diseases that can cause autonomic neuropathies and autonomic dysfunction. But here's what we do know. Sjogren's is the #1 autoimmune cause of autonomic neuropathy. So if you feel like, sometimes before people are formally diagnosed with an autoimmune disease, they kind of have a gut feeling that they have something autoimmune going on. They have a little bit of antibodies. They have, grandma had rheumatoid arthritis and their cousin has lupus, and you can't quite pinpoint exactly what they have. But Sjogren's would be the #1 autoimmune cause of autonomic neuropathy. Sjogren's is also the #2 identifiable cause of autonomic neuropathy, right after diabetes. Diabetes is considered the most common cause of autonomic neuropathy in the world, and Sjogren's is considered the second most common cause. And we know that Sjogren's, not only can it impact any organ or tissue in your body, it can impact any portion of the autonomic nervous system, from the brain all the way down to the small fiber autonomic nerves. And I don't want to scare people because not everyone has all of that, right? Most people have a little of this, a little of that, and you kind of have your own Sjogren's recipe going on inside of your body. So this is probably the most important slide because I really want to help people who have idiopathic dysautonomias, or maybe you even have dysautonomia with a bunch of other comorbidities diagnosed, like mast cell activation syndrome or ME/CFS or long COVID. If you have the syndrome soup, as I like to call it, and you have some of these features, you really might want to talk to your doctor about screening for Sjogren's, because Sjogren's is treated an entirely different way than we currently treat idiopathic dysautonomias. And it might, can't guarantee, but it might dramatically improve your symptoms and your quality of life and your long-term outcome. So if you have dry eyes, dry mouth, dry skin, dry lady parts, if you have any form of neuropathy in association with a dysautonomia, If you have significant swallowing problems, not just a transient, like for a few days I was having trouble swallowing, but like an ongoing swallowing problem. Sometimes people might get diagnosed with achalasia, which is when you really have esophageal motility problems. If you have significant GI dysmotility anywhere in the GI tract, hair loss and hair thinning is a common sign in autoimmune diseases as a whole. If you have consistent joint or muscle pain that is lasting a long time and doesn't seem to go away, if you have tooth decay or oral lesions, particularly if you have tooth decay in a younger person, right? If you're 95 and you have tooth decay, that's probably normal. But if you are 30 and you've lost 3 teeth, that, that's really not a normal thing to be happening at a young age. Significant fatigue. There is actually an article from the Sjogren's Foundation describing 15 different types of fatigue in Sjogren's patients. And I think a lot of us with dysautonomia and the related syndromic illnesses can probably relate to those, 15 different types of fatigue we get. Personal or family history of any autoimmune disease. So autoimmune diseases can run in families, but they don't necessarily run like mom has Sjogren's, therefore daughter has Sjogren's, therefore granddaughter has Sjogren's. It can be more diffuse. And in my family, I had an aunt with Sjogren's, another aunt with Hashimoto's, a grandma with rheumatoid arthritis, just sort of all over the family. But my parents and my siblings, nobody else has autoimmunity except for me. So I picked the short straw in the genetic pool. MCAS symptoms, as I mentioned earlier, mast cell activation syndrome seems to be very, very common within the Sjogren's dysautonomia population. We definitely need more research to understand that, but the sort of clinical anecdotes we hear from immunologists who specialize in mast cell and from the dysautonomia specialists who specialize in Sjogren's is that often when you treat the Sjogren's symptoms, the mast cell symptoms do improve over time. And then the other thing I would say is a lot of people with Sjogren's have non-specific autoimmune markers that are found first, like they have a little bit of ANA or they have a little bit of rheumatoid factor antibody, but not enough to fully diagnose lupus or rheumatoid arthritis. So if you just have some sort of antibodies of uncertain significance, you might want to be thinking like maybe this is just a bystander antibody to a bigger picture autoimmune problem that hasn't been pinpointed. So now I want to do a little myth busting for us here. And these are things that I hear all the time on our patient support groups of things that doctors are telling to patients as excuses, like why they can't screen them for Sjogren's. So arm yourself with this information to really try to find, you could beat your head against the wall trying to find a doctor who, trying to argue with your doctor if they don't want to screen you. The best thing is probably to just try to find another doctor. I know that's not easy for many people, but doctors who have their minds made up, it is sometimes a big challenge to try to get them to change their thinking. But here's some information that might help. So if someone says to you, there's no treatment for Sjogren's, so there's no need to diagnose it, you need to say, no, that is not true. That myth is busted. We're playing Mythbusters here in case you didn't know. So there are many, many different treatments for Sjogren's. There's no magical cure, but there's no magical cure for most diseases, right? We don't have a magical cure for rheumatoid arthritis either, but we diagnose it. So there are many different treatments for Sjogren's, and it's really important to know if you have it, even if you don't want to try any of those treatments. Even if you say, I don't want any drugs, I just want to do everything natural, that's fine. You still need to know if you have Sjogren's. Why? Because Sjogren's comes with an increased risk of heart attacks, an increased risk of stroke, an increased risk of lymphoma, an increased risk of miscarriage. Sjogren's runs in families. Like I said, not always directly parent to child, but multi-generational, kind of dispersed within a family. It is a progressive, slowly progressive, systemic chronic autoimmune. People with Sjogren's, for the most part, do not go into remission. So if you have it and you think, well, it's mild, I don't really need to do any big, serious immune treatments right now, that's okay. But you want to know you have it because it is going to be with you probably for the rest of your life. And so it's going to impact your future medical care. If it's progressive and you're not treating it, it could end up really impacting your life in a way that you don't want it to. So I have a really great rheumatologist who told me when I was first diagnosed, he said, an ounce of prevention is worth 10 pounds of cure. That's, an old saying, an ounce of prevention is worth a pound of cure. But in the case of Sjogren's, he said it's worth 10 pounds of cure. If you do preventative treatments to protect your vision and your oral health, your joint health, and your overall immune system health, you in the long term will probably be a much better managed patient, and ideally will be minimizing the impacts of Sjogren's on all your organs and systems so that you live a longer, healthier, more active life. Clinical trial opportunities are always starting to pop up more and more for Sjogren's. So this is another reason you want to be diagnosed, because maybe you want to end up in one of those clinical trials, and there are definitely going to be some new treatments coming down the pipe for Sjogren's. So another reason to get diagnosed. So here's another myth. You can only have Sjogren's if you have severe dry eye and severe dry mouth. That is also not true. And I know that Dr. Schaefer is going to talk to us a little bit about this in the Q&A too, because this is a big thing on what's a diagnostic criteria and what is a clinical diagnosis is kind of an important question in Sjogren's. But I would say some people barely notice the dryness even when it's present. As I mentioned, I have dry eye, and I never ever complain to my doctor says that's a symptom, because I don't feel it. The only way I knew I had dry eye is when they started doing eye tests on me, because I got diagnosed with Sjogren's. So the neurological manifestations of Sjogren's, like dysautonomia or sensory neuropathies, can occur up to 10 years before dry eyes and dry mouth begin. Wouldn't it be great to get diagnosed and get on treatment as soon as possible to hopefully prevent or minimize dry eye and dry mouth that might happen in the future? So here's another one. Your Sjogren's antibodies are negative, so you can't have Sjogren's. This is the biggest lie of all. And it is really something persistent we see across, even rheumatologists say this to patients. So this is not true. The internationally recognized classification criteria for Sjogren's require that you have positive antibodies or that you have a positive minor salivary gland biopsy, which patients often refer to as a lip biopsy. So importantly, Sjogren's cannot be ruled out based on blood tests alone. About 40% of Sjogren's patients don't have the SSA or SSB Sjogren's antibodies. And then also many Sjogren's patients don't even have ANA antibodies. And a lot of doctors, particularly those who aren't rheumatologists, will say, oh, if you don't have ANA, you don't have an autoimmune disease. That is not true. You do not have to have ANA to have an autoimmune disease. Really important for this audience, younger patients and people with dysautonomia or other neurological manifestations of Sjogren's may be less likely to have these SSA and SSB antibodies. So it makes sense when you are getting a workup to get tested for those antibodies. But if they're negative, the doctor can't say to you, I'm sure you don't have Sjogren's because those antibodies are negative. That is just not the way it works. So this is the next myth. Your antibodies are negative, so we are not going to order a lip biopsy. This drives me bonkers, because if the antibodies were positive, why would we make a patient get a lip biopsy? A lip biopsy is not fun. It's not the worst test you've ever had, but it's not fun. It's a little hole on the inside of your lip. It doesn't leave a visible scar, but it can leave a little bit of numbness for some people. And it's sort of feels like a bad canker sore when you get it done. So the only reason a doctor would order a minor salivary gland biopsy would be if the blood tests are negative or indeterminate. Maybe they were a little bit positive, but not enough to officially diagnose Sjogren's. So that's when either the blood work is negative and there's clinical suspicion of Sjogren's, or the blood work is sort of a mushmash of indeterminate. Then you'd want to order a lip biopsy. If your blood work clearly diagnosed you with Sjogren's, you don't need a lip biopsy. You don't want to get one if you don't need one. So if the blood work is just raging high Sjogren's antibodies, you can skip the lip biopsy. Sjogren's patients with, and I mentioned this earlier, I think Sjogren's patients with neurological involvement like dysautonomia are more likely to have negative SSA and SSB antibodies. So this is why we see in our dysautonomia population, a lot of patients saying, I was negative for these antibodies, but when I got a lip biopsy, it was definite positive, and that's when I was diagnosed with Sjogren's. So be mindful of that. Oops, I think here I skipped. Sjogren's there's another myth that it's an older white woman's disease. And historically, a lot of diseases were first described as a white woman's disease or white person's disease. And then when we did more research, we realized it affected other people too. So this is a myth that is not true. There are different rates of people of different races and different ages and sexes that have Sjogren's, but Sjogren's can truly affect anyone. Oh, sorry, I skipped ahead. Where did I go? Here you go. Sjogren's can impact people of any age, sex, race, ethnicity, of any geography. There is some hints in the research that, like other autoimmune diseases, there might be like a north-south distribution, like the further you are from the equator, the more and the less vitamin D you're getting from the sun, you might have a slightly higher risk of Sjogren's. It does affect people of all races and ethnicities, and there are differences. We see higher rates of Sjogren's in Native Americans in the US. Black patients are more likely to have Sjogren's associated with lymphoma. There's Sjogren's research happening around the world in all different countries. Younger patients may have the more neurological features. And then something I think is really interesting, and I wonder if we might see a parallel to this in POTS. Since Sjogren's is like a 90% female condition, when you have men who have Sjogren's, there was a research study from the University of Oklahoma, or Oklahoma Medical Research Foundation, which is one of the best autoimmune research centers in the world. And they found that 1 in 30 men who have Sjogren's have a genetic condition called Klinefelter syndrome, which is, instead of just having XX or XY genes, they have XXY, which gives them like an extra female chromosome, which might change. They're still considered, men, but they have sometimes some more female sex hormones or other sex-based characteristics that might influence their risk of autoimmunity. So I think this is a really interesting study. So just some practical tips before we jump into the Q&A with Jen and Dr. Schaefer. So if you want to get a lip biopsy and you don't know, like, where do I do this? Where do I go? My local doctor doesn't know what to do. So the best thing to do would be to ask local Sjogren's and dysautonomia patients who is good at diagnosing Sjogren's in our area. That would be, joining Dysautonomia International support groups to ask. The Sjogren's Foundation also has support groups that you can find on their website. Very often, if you find other patient advocates in your area, they're going to know who's good at this, who's not so good at this. When you do find a doctor, you might want to ask them how many Sjogren's lip biopsies they've done before. If the answer is like 2, I don't know that you'd want to do it with them. You have to decide how much experience is enough for you, but I would want a doctor who's done a lot of them, because they can be done wrong and they're not pleasant to get repeated. So you really want to make sure you're getting it done by someone who's pretty experienced in this, or at least someone who's being supervised by an experienced doctor. And then in addition to the doctor who's taking the lip biopsy, you're going to have a pathologist who's going to interpret the lip biopsy specimen. They're going to look at it under a microscope. And so you want to know, is this pathologist experienced with Sjogren's pathology, Sjogren's biopsies? And I'd say most pathologists in a clinical research setting or in an academic hospital probably are, but it's still worth asking, or at least when you get the report, get the actual report from them and make sure that it includes what's called a focal score. That is sort of the consensus-based way that Sjogren's is diagnosed. There are other types of scores that some clinics use that are considered a little bit more dated. The other practical tips I have is, it hurts when you get this lip biopsy. It doesn't feel so great. So I would say check with your doctor, because I'm not giving specific medical advice. I spelled numbing wrong, so sorry about that. But Chloraseptic sore throat numbing spray was my best friend when I got a lip biopsy. I was spraying the biopsy site before I ate, so that it would just numb it for a few minutes so that I could eat dinner in peace. There is something called magic mouthwash that a lot of Sjogren's patients use. It's a combination of things like Benadryl or liquid lidocaine and other kind of things that kind of soothe the mouth. So that's sometimes used. I mentioned liquid lidocaine separately. I would say don't eat nachos or scratchy stuff right after you get that biopsy. It's not going to feel so good. I would, plan for a few days of soup and pudding and smoothies to kind of let your lip heal. Thankfully, the mouth heals pretty quickly in most people. So that is something to just keep in mind. So a lot of times when people get diagnosed with Sjogren's and they have a dysautonomia or other neuropathies, they want to get on IVIG. So I'm, it's really important to understand that there are no large research studies demonstrating that IVIG works for Sjogren's. However, most doctors, most neuromuscular specialists and autonomic neurologists do use this fairly often in Sjogren's patients. So we really have to push for those clinical trials to happen, because that will make the insurance approval process a lot easier for people if the trials show that IVIG actually works. So for now, it's pretty hard to get insurance approval for it, even if you have a formal Sjogren's diagnosis. I would say the best thing to do would be to find a doctor who has obtained IVIG successfully in the past for other Sjogren's patients. They probably have a book of appeal letters that they have already pre-written for other patients that they could borrow for you. You have to almost always have to appeal because IVIG is so expensive. Insurance companies pretty routinely deny it, and they just count on a lot of people are not going to appeal because it's too much work. But you have to appeal and appeal again, take every right of appeal that you have in your insurance plan. And you have a better shot at eventually getting it approved. If you do get it approved, really, really super hydrate orally and try to get some IV saline before the first IVIG dose. The first dose is always the hardest on your body. You're not used to it and your immune system is kind of getting a bit of a shock to the system. A lot of patients take Tylenol or Toradol, obviously with your doctor's supervision. I also would tell people to use a slow and low IVIG dose until your body adjusts. So when you're new to this, the IVIG dosing can be pretty confusing. We have other videos on this on Dysautonomia International's Autonomic Disorders video library, which I'll share a link to at the end, that explain the rate of dosing and the total grams per month based on body weight and all that, it's a little complicated, but once you get the hang of it, it starts to make sense. Also just emphasizing IVIG is not a magical cure. Even if it works exactly how it's supposed to work and you get the best benefit out of it possible, if you have been sick for years, you probably still have to rehab your body and do other things to help your immune system function as well as possible. And I do a lot of this myself. I did get access to IVIG for about a decade. I'm actually off of it now, which was terrifying to me when I first went off it, but I'm thankfully, knock on wood, I'm doing okay right now. But, lots of good, healthy lifestyle habits are all things that are also supporting your immune system. Good sleep, a nutritious anti-inflammatory diet, certain supplements might help, which of course, talk to your doctors, but things like turmeric, ginger, vitamin D, there are a lot of different things if you do some reading and sometimes help consulting with a holistic type practitioner that really has taken the time to understand autoimmunity and all the little things we can do. They sometimes can add up and really be helpful. So practical tips on dry mouth. There are lots of different products for this. I like xylitol products. These ice chips candy are made of xylitol and they come in all different fun flavors. I like Basic Bites. They're these little chocolate chews that have a pH balance to them. You might want to try toothpaste with no SLS in it, especially if you get a lot of mouth sores, whether you have Sjogren's or not. I actually think it's worth trying that if you get a lot of mouth canker sores and such. In Sjogren's, preventative care is super important. So get a dental cleaning every 6 to 12 months. Talk to your doctor or your dentist about mineral rinses that can be used to protect your teeth. They remineralize your teeth, that you might be losing mineral density in your teeth if you have dry mouth. You can talk to your doctor about medications that can increase your salivary flow. You got to do the old-fashioned brushing and flossing. don't take little sips of water all day. That's a thing that I think a lot of us tend to think, oh, I have dry mouth, I should take little sips of water all day to keep my mouth moist. What that actually does is it rinses away the saliva that you do have, which has immune protective properties in it. So it's better to sort of, drink a bunch at once than do little sips throughout the day. You definitely want to stay hydrated, especially if you have dysautonomia, but the little sips is going to wash your saliva away. Don't consume excessive coffee and alcohol, which are pretty acidic on your teeth, and excessive junk food. Don't ignore dental problems when they begin. You want to address them quickly because they can rapidly get worse. And then if you do have major tooth problems, don't jump right into getting dentures. Try implants, dental implants, if you can afford it. They're pretty expensive, but dentures in people with Sjogren's can actually cause even more problems if you have chronic dry mouth for the rest of your life. And then you put dentures in, you're sort of breeding infection and irritation and inflammation and a lot of pain. So, implants, I wish insurance covered them for people with chronic dry mouth. I think that would be an advocacy issue that would be worth all of us fighting for. So just really super quick, I'm going to mention our Dysautonomia International Research Program and the 4 different Sjogren's related projects we have supported. One was a study I'm doing with my local neurologist here, Mark Gudesblatt, on the novel Sjogren's antibodies. I'm sure many of you have heard of them. So they're not considered diagnostic for Sjogren's at this point in time, but we did actually find these antibodies in 41% of idiopathic dysautonomia patients who had either dry eyes or dry mouth. So that was interesting. And it suggests that we probably need more Sjogren's screening within the dysautonomia population. We are funding the first POTS IVIG clinical trial, and we added a branch to that trial of a Sjogren's cohort. And the Sjogren's Foundation chipped in some of the money to help with that. So we're very, happy. Dysautonomia International and the Sjogren's Foundation have been working together to advocate for more research on the overlap between these conditions, and we very much appreciate their support. We're also funding a novel ganglia biomarker study in Sjogren's and POTS at Johns Hopkins. So Johns Hopkins has Dr. Tae Chung, who is a famous sort of POTS doctor running a really great POTS clinic down at Johns Hopkins in Baltimore. And Johns Hopkins also has one of the top Sjogren's research centers in the world. And so there is a rheumatologist there, Dr. Britt Adler, who's partnering with Dr. Chung they're looking at different antibodies that might be affecting the autonomic and sensory ganglia in Sjogren's patients as well as POTS patients. We're also funding, this is a very long study title, but I put it in, when we get grant applications, they never have nice, neat study titles. Like this one I made that title up. It's actually a much longer title that wouldn't fit on the slide. But this is Dr. Nora Singer at Case Western Metro Health in Ohio, is a systems immunology approach to dissecting the role of neutrophil netting, anti-GPCR antibodies, and coordinate monocyte-driven inflammation in the development of POTS, both in the presence and absence of Sjogren's. So big picture, what is she doing? She's doing like an immune system profiling in people who have POTS with and without Sjogren's and comparing them to see if there's anything unique or different. And this will get us great information on POTS immune system stuff overall, as well as the Sjogren's POTS relationship. So there's just some helpful links here. And with that, I wanted to bring Jennifer and Dr. Schaefer back on to join me for a Q&A. Hopefully you guys have been asking some cool questions. I'll leave this slide up just for a moment in case anyone wants any of these links. This is Dr. Schaefer's website, Sjogren's Advocate. It is a wealth of information that I use her information all the time. I love it. The Sjogren's Foundation is also on here. These are some Dysautonomia International links up top. And, there are so many patients who have these conditions undiagnosed. And I greatly appreciate the work of Jennifer and Dr. Schaefer and the Sjogren's Foundation, trying to get more people accurately diagnosed with what they actually have. So with that, we'll turn it over to Jen to help lead our Q&A.
Okay, so we've been looking through the questions. And the first question is diagnostic criteria. What is the diagnostic criteria for Sjogren's?
I'm going to pass that to Dr.
Yep,
Schieber.
that's me. I have a whole section on Sjogren's Advocate on diagnosis. There are no diagnostic criteria. That is so important to understand. You can have Sjogren's and not fit the classification criteria, which are a narrow set of criteria that are used to standardize research populations. So on purpose, they leave out a lot of Sjogren's patients. Unfortunately, many doctors, rheumatologists included, mostly rheumatologists actually, will assume that you don't have Sjogren's if you don't meet the criteria. And I cannot tell you the number of people I know, including myself, who did not meet the criteria for years with very, very full-blown symptoms. And you're less likely to meet the criteria if you present with neurological features, including dysautonomia, which was me. So the criteria are it's a scoring system of 9 points. There's 3 points for SSA, 3 points for lip biopsy. You got to have one or the other, and the other 3 points are dryness measurements. And many people do not meet those criteria who are young, who are neuro presentations, and there are other systemic presentations. 20% of people present without dryness. So that's a lot of people, but they usually are, we know it from retrospective, histories, but it's a lot of people, but they don't get diagnosed for years. And I was one of those. So it's actually, I had dryness, but I still didn't get diagnosed.
No.
So
oh, go ahead. Sorry. I just put a link to the Hopkins American European criteria website, which you probably.
Yeah, it should be the 2016 criteria, which I think is what's on Hopkins. I have a classification criteria page on Sjogren's Advocate in my diagnosis section. And basically what I do on my website is I walk you through how you understand what these criteria are and how doctors think about them and what you do to counter their misinformation. So I'm all about tools. Like the Sjogren's Foundation, does all this research stuff, a lot of big picture stuff. And I'm into the nitty gritty of how do you get the care you need. And I don't, my website's a work in progress, but anyways, that's how you should use it, is okay, what paper do I need to show this doctor that, that classification criteria are not the be all and end all. And also I highly recommend Smart Patients for patient support. We have a list of rheumatologists, and people can go on there and say, who have you seen that will diagnose seronegative patients? And you have to accept the fact when you have Sjogren's or dysautonomia or both, that care is not what it should be for complex, severe chronic diseases. And you have to do your homework, and way, way more than you would for another serious disease. A diabetic doesn't have to explain to their doctor what diabetes is, but with Sjogren's and dysautonomia, you're often put in that position, and it's horrible. But I actually have pages on my website, like handouts for clinician. How do you talk to your doctor? How do you choose a handout? How do you do it without insulting them? How do you find out if they're going to be impossible to work with versus somebody you can work with? So yeah.
I have printed out stuff off of your website to give to my physicians, and it does help. When you have a resource that is peer-reviewed research, it really helps.
Yeah, I just want to put in a thing. In general, I refer you to primary materials. If you just print out a page from Sjogren's Advocate, unless they're open, they don't know who I am. And I'm not part of an organization or an institution or a university. So if they don't know who I am, they'll just see this, even though it's highly cited. Unless I say it's a handout, I recommend going to the primary sources. And I give you those. I say,
yes,
like I have on the autonomic disorder page, I have something called, I never print out my website, but here it is, top misperceptions, and how to counter them. And you can actually go there, and if you're SSA negative, and they tell you that only SSA and SSB really get systemic problems, so then you can't possibly have something serious going on. I actually give you journal articles that you can print out. And I actually tell you what paragraph or what sentences to highlight.
yes.
I walk you through the actual steps to take to counter the myth busting that, by the way, Lauren, great job with the myth busting. Those things frustrate
Yes,
the
we
heck
need
out
a lot
me.
of those.
I borrowed that. I did that one time with the actual funny, we made the Mythbusters logos for ourselves and with the funny hat like Jamie had, and
Yeah.
that was we did it in a POTS session when we did POTS myth busting. So every disease probably needs a myth.
Yeah, I have a future page that's going to be gobs of information and handouts on myth busting, but you know, right now you can use the search bar and find what you're looking for, like look up SSA and you can find a whole bunch of pages with that on it.
Yeah.
So, yeah.
Another question, what is the first line treatment for Sjogren's, second line treatment for Sjogren's disease?
I can start, but you're going to finish this. You're both the clinicians and I'm just the patient too. I would say the first real big picture answer is it really depends on what your manifestations of Sjogren's
Right.
are. If you only have dry eyes, then that's what the clinician is going to focus on. If you have raging neuropathy, then that's probably what the clinician is going to focus on. But I think, Jennifer or Dr. Schaefer could give us an overview of like the common treatments used in Sjogren's.
Yeah, I would say exactly what Lauren said. Is based on what your symptoms are. If you're not diagnosed, you need to seek out a diagnosis for what is going on. You could have the triad of fatigue, very generalized fevers, fatigue, pain, dry eyes. It's very general. A lot of doctors do not see the whole picture of it. And treatment is more, you could use eye drops, doing mouth oral care. I go every 3 months to my dentist because I presented with a lot of oral mouth decay in my early 20s. And I was not diagnosed with Sjogren's until my late 30s. So we didn't know. So we were just treating the symptoms, but not treating the underlying cause of what was going on. I'm big on trying to find the root cause of why do you have these symptoms. Dr. Schaefer, I know you could probably elaborate on that.
Yeah, I don't know how much depth to go in. I mean, I'm not going to go to great detail,
Right.
but there's no one. First of all, there are both lifestyle and medication approaches, and I throw the kitchen sink at it. I do a lot of lifestyle things, but I also take a lot of medication. So there's no one treatment that works the same for every person. Even eye drops, like somebody will react to a particular brand of artificial tears. And there's no one, every Sjogren's patient is unique. It's an incredibly complex disease that impacts the entire body. So if you've got a really heavy duty neurological complication versus lung disease versus more sicca heavy, and by the way, every single person that thinks that they just have dryness has a systemic disease. It's never just dryness. So the question is, should everyone be put on hydroxychloroquine? There are inadequate studies to show whether it prevents progression like it does in lupus. We're very closely related to lupus, and it has a remarkable benefit in lupus. It's malpractice not to treat lupus with hydroxychloroquine. But with Sjogren's, there's only one study and it's horrible, and I won't go into why it's horrible. It's inadequate. So there are retrospective studies that show, yeah, it looks like it does prevent progression, and I think it probably does. I have a whole page on my website, a blog post about it, so you can always look that up. But usually for systemic treatments, hydroxychloroquine is the starter thing. It's very frustrating. It takes months before you even notice the difference, and it's so slow that you may not notice it. Not everyone benefits from it, but I find about 80% of people feel better on it. And then methotrexate is often used for people with predominant joint pain. If you have lung disease, depends on what type of lung disease you have. And, so we could go on and on, but it really depends on, and you often need to see multiple specialists. And there's also comorbidities. I mean, part of good Sjogren's care is both the sicca and the systemic, which is the non-sicca or non-dryness manifestations, quality of life, which is largely related, I think, to dysautonomia. That's my personal view. And which none of the rheumatologists seem to know anything about or know how to help you. And comorbidities. We have much higher risk of cardiovascular disease. And then there's immune comorbidities. Like, for example, one of the red flags for diagnosing Sjogren's is thyroid disease and celiac disease are at very high rates in Sjogren's patients and vice versa. So if you've been diagnosed with celiac or Hashimoto's and you've got Sjogren's symptoms, you really need an evaluation. So that's another part.
Yeah. We talk, the three of us talk about these comorbidity things, like just throwing these terms out, and it's like, because we've been living with it, I have, I'm a pretty high functioning POTS patient now. I wasn't in the beginning, but I'm pretty high functioning now, but I have from Sjogren's, I've been diagnosed with autonomic sensory and trigeminal ganglionitis. I had really terrible esophageal dysmotility, like it caused me a 60-pound weight loss in a few months. I had interstitial lung disease from Sjogren's, recurrent autoimmune pericarditis. So my heart just gets inflamed for the hell of it all the time. I just recently learned, actually, there is a new or new-ish, at least new to me, interleukin-1 inhibitor drug for recurrent autoimmune pericarditis. So that is not a standard Sjogren's treatment for everyone, but if you have recurrent autoimmune pericarditis caused by Sjogren's, now you have a new treatment option specific to that problem. Sometimes you'll hear about patients going on Cellcept, which is a pill that's like, I think of it as Rituxan light duty. I'm not sure if that's the right way to think of it, but that's how I think of it. It's probably more potent than Plaquenil, but maybe not as potent as Rituxan. And Rituxan is also sometimes used in really severe cases. But these are drugs that you don't take lightly because they are immune suppressants and they can cause other complications, so you really need it to be put on.
That's not true of hydroxychloroquine or Plaquenil, though. That is not an immune suppressant, and a lot of people think it is. Like, if you're getting vaccines, you don't have to stop it. It doesn't change your risk for getting an infection. So that's really different. So
I'm on Plaquenil. I haven't had any issues with it in that way.
I
never thought of it as an immune suppressant ever.
It's an immune modulator.
Yeah, I was thinking more of like the methotrexate and Cellcept and Rituxan and
everything. Pretty much everything else wallops your immune system. Well, I guess IVIG is different, but most of the other drugs do. Yeah. So you have to be really careful.
Steroids are really helpful for acute Sjogren's flares, but they're not a good long-term solution because Sjogren's, being a lifelong disease for most people, your body has only a certain amount of tolerance of steroids before it starts causing really big long-term problems for you. And I actually did get some of that. I got bone density loss in my feet I wasn't using steroids every day. I was getting them weekly before my IVIG infusions to prevent reactions to the IVIG. And then I ended up with bone density problems because of that. So now I can't take steroids unless it's like a life or death thing.
Yeah.
And
I fractured my spine.
Yeah, scary.
That was not fun.
No,
and that's osteoporosis induced by steroids, which I had to be on because, like, you had pericarditis, I had peritonitis, which is really a weird thing to have happen in Sjogren's, but it does. So
yeah,
I was on steroids also in the beginning for every itis you can think of in my 20s, hospitalized, mastoid, I mean, you name it, I had it. And it took about 4 years to get off of the steroids. My body
hard.
It was a titration down to, I was on like 0.025 at one point. My body just wanted it. And when I would go down, the fevers would return, the fatigue would return. I had uveitis multiple times. It just, it's a difficult drug. Now I do pulse steroid. I'll do like 3 days of an IV, 1,000 milligrams, 3 grams over 3 days. And it just knocks me right out of whatever flare up I'm in. But again, there's a lot of risks with that.
Yeah. Jennifer, you have done a lot of work on sort of changing your lifestyle and your diet. And I've known you long enough to watch you sort of transform.
Yeah.
like the lady that had all the itises to, still having Sjogren's, but doing a lot better. Do you want
Yeah.
to just talk about like dietary stuff? And I know like when you're a chronic illness patient and you're really searching for answers, sometimes it's really frustrating for people to be like, yeah, just change
I tried, yes, I
Yeah.
tried everything as a health professional. I looked at it very logically, and I always felt I ate very well, which I did. I had a lot of steroid weight on board, and during COVID, I just wanted to turn it around. I was afraid of obesity as a comorbid factor for COVID because I'm also immune deficient. I have I have gamma globulinemia, so I'm also on IVIG for that. And I went on a specific program that really refined sugars, gone, gluten, just about gone. And in 4 days, I had very bad chronic colitis. In 4 days, that went away. It was a side effect of the program I did not expect, that it basically cured my colitis, and I have not had, knock on wood, had an issue since, but it was controlled. I'm gonna say, I hate to use 100%. For me, it was controlled 100% through dietary restrictions of things my body did not. It just would create inflammation. If I had one extra piece of watermelon, the sugar would just put me over the edge. So I have to be on a very strict regimen of 120 carbs or lower, no gluten, just very FODMAP type diet. And it really has helped with all the itises. I haven't had to take steroids in almost 3 years. And it's just been amazing for me. It's worked for me. Does it work for other people? Sometimes it may, but for me, it was a fantastic turnaround.
I have.
I want to say something about inflammation and markers. Is that okay? Or do you want to say something
Absolutely.
first? Lauren, okay.
Okay.
So I did see a question. I was trying to watch the questions as Lauren was talking. People were asking about sed rate and CRP and inflammation with Sjogren's. So Sjogren's actually is an inflammatory disease, but it is not, the sed rate and CRP are not associated with the severity of the disease or the severity of inflammation. So any doctor that tells you can't have Sjogren's if your CRP and sed rate are normal is wrong. It's another mythbuster thing. CRP is usually normal in Sjogren's, and if it's high, you need to look for another cause. And that could be another disease like the spondyloarthropathy. Somebody asked about psoriatic arthritis. Yes, that's associated. Or it could just be all the other things that cause elevated CRP. Sed rate is often associated with when it is elevated in 30% of people with Sjogren's. It's associated with elevated IgG, which is, sed rate is not a specific thing, but the IgG is just B cells being hyperactive and spewing out antibodies, and that raises your sed rate. So it's not necessarily a symptom of, a measure of inflammation. There are lab tests that can be done in research settings that do show inflammatory molecules that are elevated basically in all Sjogren's patients, but they're not readily available. They're not standard tests. So anybody tells you you're not inflamed because your CRP and sed rate is normal is completely wrong. So you have to we just have to fight like myths all the time. So
I know we're over time, but I'm loving this conversation. And if you guys need to go, let me know, but let's keep chatting if you don't.
I'm good.
4 minutes.
I got my fluids on my eye drops. So
I have a question. If the Sjogren's is treated and under control, will your dysautonomia go away?
So probably the answer is very different for everyone. It's not a science-based answer because we don't have clinical trials on this right now.
Yeah.
But we have seen a tendency for dysautonomia to improve to some degree in many people when they treat their Sjogren's. But it's not a sure thing, right? I have POTS Sjogren's friends who've been on all the immunotherapies, have the best doctors, do all the lifestyle stuff, and they can still be pretty sick with POTS. My own case, I knock on wood and, feel lucky. When I went on IVIG, I had a dramatic improvement in my dysautonomia, but it's sort of based on where you're at too. What is the improvement from what, right? I
Right.
was just flat out bedridden for 2 years. And so when you go from bedridden to like being able to drive to the food store, it feels like a huge improvement, right? But if you were a 5K athlete before that, being able to drive to the food store doesn't feel too exciting. It's like, I'm still sick, you know? But I would say for me personally, very slowly over time, I did all the immunotherapy, I did all the lifestyles, 1,000,001 lifestyle things, which don't come to you on the first day, right? Like to become a habit that's become routine and not, it doesn't feel like a chore anymore because I just do it. But when you first start doing those lifestyle things, it is an effort, right? Like, oh God, I have to remember to take this and to do that and to get to bed on time. And once you build small, slow habits one at a time, then over time they just become your lifestyle and they don't feel like a big burden anymore. And then if you, especially when you see benefits from them, then you're just grateful that you have that as an option, you know? So for me, I actually found that very slowly over time, I was able to build up my, I would call it activity tolerance, probably more than exercise tolerance. And that's obviously a huge issue in dysautonomia, is that many of us have a really hard time getting exercise or even just walking, right? And so that has helped me. And I looked into like Sjogren's itself. Is there research showing that exercise can be part of the management of Sjogren's? And there does seem to be some good research for that, not only in Sjogren's, but in lupus and RA and, you know, most chronic diseases. So I think that's something we probably struggle with a lot in the dysautonomia community, because our dysautonomia makes it so hard to exercise. I don't know if you guys have any thoughts on that. Have you found, you know, being active? I sometimes think we get stuck on the word exercise because people assume that means getting all sweaty in the gym and running on a treadmill, right? I think exercise could be like, I walked to the mailbox, I did the dishes today, I put my laundry away, like just it's activity.
I'm a success story with an exercise program. I was very athletic before I got incredibly ill. I was bearing with Sjogren's and POTS for a long time, and then I had a demise. And at the time, I had been swimming every day, like about a mile a day, or most days. And I have a history of swimming. And, you know, when I was younger, I did triathlons. I mean, I'm a jock. So this was devastating to me because all of a sudden, like overnight, I couldn't swim more than a lap at a time. And I was gasping at the end of the pool because I had undiagnosed POTS. And I just didn't know what was wrong. So for 10 years, that's how I swam. I could barely drag myself to the pool and get in, but that was the only kind of exercise I could tolerate. I literally had to lie down on the sidewalk when I went on walks because I'd feel like I was going to faint. And I didn't know what was wrong. Finally, that got better. But it's interesting because the people with long COVID POTS and that kind of thing, there's a whole thing about the PACE trial and whether it hurts or help. And what if you have, like, I qualify as an ME/CFS diagnosis according to their criteria, but I think it's different because I do have post-exertional malaise. If I go outside of my exercise envelope, I can't do what I could do if I weren't sick. I get a lot of PEM, post-exertional malaise, if I do a lot of cognitive work, like, you know, talking after this, I'm done, like for the evening here, and I'm in California, so it's not late. But I learned through the Levine protocol. I adapted it to myself. Don't use the Levine protocol. Thank God I knew to adapt it. That I added in high intensity interval training into my swimming very slowly. And after 3 months, it increased my cardiac output. I was much more functional with my POTS and, you know, my upright time. So that was an amazing finding, but you need support to do this. And I have a history of athletics, and I know what gasping for breath that won't hurt you feels like versus what gasping for breath that will hurt you feels like. And most people don't know that. And you have to be willing to go through a lot of trial and error and discomfort to have it help you. But that was part of the protocol, was doing the high intensity intervals. And it was so hard at first. And I just started off with 1 lap I'm talking one length in the pool doing hard kicking. And then I slowly added over the next couple months, and it was a game changer for me. So
I think the activity issue is an exercise issue. It's really, I wish that like the Levine protocol is out there. We have a modified version of it on our
yeah,
website.
the CHOP is closer to what I did. Yeah.
Yeah.
So if anyone is interested, that's dysautonomiainternational.org/exercise. And there's a bunch of tips there, reclined exercises, pool exercises, the CHOP protocol that was written by Dr. Jeff Barris, kind of modified version, a little bit more practical than the Levine protocol.
Mhm.
But the real problem with those sort of regimented protocols is that it doesn't meet the patient where they're at, right?
Yeah.
If you're a patient who has Sjogren's dysautonomia, and let's say you're a nurse and you're full-time and you're on your feet all day in the ER, you have a different exercise capacity or activity capacity than the patient who's bedridden for the last 5 years, right? It's totally a different rehab situation.
Yeah.
And so I think we need these, what I would think of as rehabilitation protocols that assess, I mean, that's what a PT does in real life.
What,
They
need professional help.
Yeah.
Yeah,
And-
you can't do it on your own or over the internet. It's just
Yeah.
not possible. I had to start very slow as well, in bed, just lifting my legs, doing isometrics. I graduated to a recumbent bike maybe 2 months later. It was a very, very slow, very, very slow.
I think there's also an economic challenge for people. Like,
Mm.
so if you are a single mom with 3 kids, and you know that when you exercise, you are going to feel worse for a few days, it's very hard to say, well, I'm just not going to take care of my kids for the next 3 days.
Right.
So it's really like, I think there are some economic disparities in who can do it.
It's more, I think that's more of as a mother, I think it's more of a problem getting time for yourself to do that. But I did it in a way such that I made sure that I did not have kickback. So I added the 1 lap, and I was okay pretty quickly after. And if I wasn't okay, if I added stuff too quickly, I backed off.
Yeah, the goal is to not over.
If you react for 2 days, you've really gone out of
You
your
overdid it.
envelope.
Yeah.
You've
Yeah.
really overdid it. So, we're talking a lot about the lifestyle stuff, which is really great. I'm just wondering, there were a lot of questions in there about the lip biopsy and diagnosis. I wonder if we want to go back to that.
Yes.
Can I pull a good one here? I know Jen's doing the questions, but I thought
Yeah,
this
go ahead.
is, so is it possible to have Sjogren's with all the symptoms, but negative Sjogren's blood work and negative lip biopsy? There's inflammation in the lip biopsy, but not enough to call it official Sjogren's.
Yes.
Yes.
Yes. And I have like 30 articles in a file on which eventually I'll do a better like MythBuster thing. So the minor salivary gland biopsy is only positive in 80% of patients who have positive SSA. It's never been tested against anything but people who are positive for SSA. So when a rheumatologist tells you, well, if you don't have a positive biopsy, you can't have Sjogren's, they're completely wrong. And I have met so many people who have stories like mine, which is I had a lip biopsy at age 44 when I had my demise that I mentioned. And I was so sick, and it showed diffuse lymphocytic infiltration, no focus score, which is basically they organize into these like clusters of dysfunctional gangs around your salivary glands. And I've always been antibody negative, the whole 9 yards, no positive antibodies ever. And I was sick. I knew I had Sjogren's, and my rheumatologist said, well, I don't think you have any autoimmune disease because you're negative. So I took the literature in and convinced him and showed him how there were seronegative patients. He actually changed his whole tune and started diagnosing a bunch of seronegative patients after me.
Oh, wow.
So, but a lot of people still won't do that. So then 7 years later, I went over to see Ava Wu and enrolled in the SICA study. And by that time, also my oral dryness had progressed. My eyes were very bad early on, but not my oral. It was always dry, and I had a positive lip biopsy, a focus score of 1.5. It's got to be 1 or more. Okay. So I had a score, my classification criteria at 6 out of the 9 points at that point, because I had everything but the SSA. 2
Mhm.
years later, because Ava is just so good at doing the lip biopsy, I had a third lip biopsy for the study. And no,
Wow.
I literally ate immediately after rice cakes. She
Oh.
just did tiny little snips, no stitches. She needs to train everyone how to do these. So I went back, had a third one, atrophy and scarring. What happens when you have long-term damage is it just fibrosis. It turns into a big old scar and shrunken veins. So I fell out of the classification criteria. I now had a score of actually 2 because the autologous serum eye drops healed my eyes. So I would score from 6 to 2 in 2 years, but I was just as sick.
Can you explain to people, I think these are fascinating. Can you explain what the autologous serum eye drops are? Because I think it's
They're eye drops made out of your own
Your
blood.
blood,
You go
yeah.
and you have a big blood draw. They take it, they send it to a compounding pharmacy, they spin it down, they take the red cells out, leave your serum, send it back to you, you keep them frozen, you put them in your eyes, and they have incredible healing properties. And I was one of the earliest patients on it because I heard about it through a group, an online group, and I just insisted upon getting them and paid out of pocket for a while until Kaiser started paying for them. And they've been a godsend. My corneal erosions are gone. I mean, they were completely healed by the eye drops. So,
Amazing.
I wish
and I can't stand, I took a year of Restasis and danced around the room screaming every time I put them in, even though they were cold, because they just were brutal.
They burn.
that's a good tip for people. If you are given Restasis, put it in the fridge because
Fridge.
it hurts a
Put it in
little
the fridge.
They still
It
burn
is,
a
it's
little
still
bit.
burn.
They still burn.
I'm the opposite of you. That's another warning sign of Sjogren's is if your eye exam does not match your pain level. My eye exam right now is great. It looks fine. I have terrible pain. Not too bad, not as bad as it was before the autologous.
ocular pain or
Eye pain.
eye pain.
Yeah, from neuropathic dryness, ear inflammation. So you have no pain and no sense of dryness. I feel incredibly dry. So
I'm
you have no pain
incredibly
and no sense
dry.
of dryness,
No pain.
but you have damage.
Like corneal damage
Yeah.
so bad that my glasses, they actually told me we can't give you glasses that correct your full vision because your cornea is all like wavy.
That's not
like, great.
that's not correctable. You have to repair the ocular surface.
You might
So-
have to get the
so
drop,
that's-
Lauren.
That's a big
I'll
red
write
flag
down.
for Sjogren's. Either
Yeah.
your pain is a lot less or your pain is a lot more than you would imagine from looking at it with the special staining they do in the slit lamp exam.
Yeah. So
Yeah, so different.
finding doctors that know about this is a challenge for any like poorly understood chronic illness. So I would say definitely talking to fellow patients, like who is the good
Yeah.
eye doctor in our area that knows this? Who is who's on the board of the Sjogren's Foundation? You can look on PubMed.gov and see who's publishing on Sjogren's.
That's not always a
Not always
guarantee, though.
perfect, but it's
I would say Smart Patients is the way to go around Sjogren's referrals and your local support group. I actually know personally several famous Sjogren's experts who will not diagnose you if you don't fit the classification criteria, even if people have what I call fulminant Sjogren's signs. And
Wow.
it's very traumatizing to people who clearly have Sjogren's. And
There was a story at the Sjogren's Foundation conference several years ago, a pediatric patient. So usually Sjogren's is diagnosed in middle-aged women or older, but there are pediatric cases and they can present very severe. And it might be that only the most severe kids get diagnosed, because if you're like mild, then no one's probably thinking of Sjogren's when you're 12, right? But there was a young woman who what they were describing is that they went to Mayo Clinic and they went to this big fancy rehab program and they got her exercising again. And it sounded to me like the Mayo Clinic POTS rehab program, right? That is pretty aggressive on the exercise and the psych stuff. It doesn't work for everyone, but some people think it helps them. So anyways, they did all this. And then the kid was very, very sick still. And the mom called the clinic and the program and said, it didn't work. Like, what should we do? And they kind of gaslighted her and said, well, you're coddling her too much, or just send her to school, like kind of, So then the family happened to move and they saw some other doctor, and the other doctor was like, your kid has like raging Sjogren's and needs to be inpatient getting Rituxan right now.
Yeah.
Like, so I
Yeah.
think about, how many young people out there are dealing with that and just being told, oh, it's just POTS, oh, it's just chronic fatigue, oh, it's fibro, whatever, like, and it might
Yeah.
actually be a treatable autoimmune disease.
When you survey patients, at least close to a half of them can recognize symptoms starting in adolescence or in their 20s. I had symptoms in my teens. Yep. So it's not a disease of middle-aged women. First of all, it doesn't go away. So the older you are, the more likely you are to have it, because it just keeps adding on. But most people start much, much younger than middle age. It's just that it doesn't get diagnosed. And it's like when it gets really bad, or they finally run into somebody who knows something about Sjogren's, that it gets diagnosed. And that's usually middle age. And it's ridiculous. And we don't know how much treatments could stop progression, because it's like gospel rheumatology care. Like I just saw a little video about RA that's like, it has been shown that early and aggressive treatment results in better outcomes and less progression. Well, what about Sjogren's? Well, there's no early, they don't even treat you when you're advanced, because they say, oh, it's just sicca, so
Yeah.
We are decades behind other diseases, and it's just crazy. So you really have to be your own advocate.
I see a
Absolutely.
similar concept in so one of the autoimmune conditions that sometimes overlaps with Sjogren's and dysautonomia is antiphospholipid syndrome.
Yeah.
There's this mindset amongst the APS doctors or rheumatologists that are diagnosing and treating it, or hematologists sometimes, that we don't diagnose it until this person has had a massive blood clot. Like,
yes,
why?
I know.
Not dead before
Yeah.
deciding to diagnose and treat them. If we have advanced biomarkers that can tell us this person has antibodies that cause blood clots, why would we not do something, even if it's careful monitoring? Why would we not do something
Yeah.
before there's a life-threatening situation? And I think that this is a systemic problem of not recognizing the serious systemic nature of autoimmunity. And also, I hate to say it, but I do think some of it is because most autoimmune conditions are female predominant. And there's just this very long history of women's health issues aren't that serious. It's just your lady.
We have a culture that accepts women's suffering is what it boils down to. And, it's not just not being believed. It's just like, well, it doesn't matter, And I feel like if somebody, like I was a practicing physician hanging on there with my job despite being sick. And I had this demise, and I lost my career. I lost so many things. I had 2 kids and school-age kids, and I couldn't do anything. And it's like, there was no sense of urgency to figure it out.
Right.
It took me a year to get all the tests that I needed. And then I figured out what was wrong with me, because nobody seemed to care.
Yeah.
And I had a good internist, so it's horrible.
I think we should take maybe one more question. Jen, do you want to pick the final question? We had literally, I'm sorry to everyone who didn't get their questions answered. There's 138 questions.
There's so many good ones. I mean, what would be a nice meaty one? I mean, there's so many overlapping.
I like doing like rapid fire questions with like yes, no answers, even though every answer takes a 20-minute, every question.
It does take a
20-minute answer.
I have one.
Is a lip biopsy the only confirmed method for diagnosis?
No.
No, right.
And if it's negative, it doesn't mean you don't.
It doesn't mean you don't have. Yes. Can Sjogren's atrophy your vocal cords?
I don't know about atrophy, but I know that I had, because of Sjogren's,
Make it affect, yeah.
I had what's called recurrent laryngeal neuralgia, and the name of the nerve is actually the recurrent laryngeal nerve, because it makes like a loop. It doesn't mean like you have lots of neuralgia recurring.
Right.
Recurrent laryngeal neuralgia, which actually sort of messed up my vocal cord on one side for a while, and it was giving me horrific breathing problems. And when I would go to the ER having one of these breathing attacks. They'd be like,
Yeah.
your saturation's 100%, you're just having a panic attack. And I'm like, no, something's wrong with my throat.
But-
And finally I happened to, lucky me, have one of these attacks at the neuro ENT's office. And he scoped me as it was happening. He was like, oh, look at that, your vocal cord's not moving at all. So
Yeah, so I would say it's uncommon, but yes, it both neurologically and inflammatory for that reasons. And somebody had actually asked about dry airways and what you can do.
Yes,
Chronic
what you can do.
cough impacts over half of people. Humidifier all the time. Keep
Yeah.
your house at 50 degree, 50% humidity.
move
And
to a
cooler.
more humid climate and or an oceanfront community or a lakefront community, like try to live somewhere with humidity.
Yeah, like we can all do that, but yeah.
No, I know we can't all do that, but if you can do that, it could be helpful. And then having humidifiers throughout your house is important, and making sure you change the water often so you're not like spewing.
And clean them,
Yeah.
you know.
Yeah, you have to clean them.
It's a project.
I want to mention something on the lip biopsy. If you were
Yeah.
ever a smoker, tobacco smoker, or tobacco chewer for any length of time, you probably have a better chance of having a negative lip biopsy, even if you have Sjogren's. And there's a really sort of obscure and interesting reason for that. So tobacco has nicotine, which stimulates the parasympathetic nervous system. So there's a very slight protective effect against certain autoimmune diseases in smokers. I'm not saying advocating for
For smoke.
I'm not saying to smoke.
I've never heard that.
No, it's
million
true
other
for
reasons
It's
why
true for
you should-
Sjogren's.
You should not
Yeah.
smoke, but nicotine basically stimulates those parasympathetic nerves, and that's part of why smoking is relaxing, and so like it feels nice to people when they feel relaxed when they smoke, because they're getting nicotine stimulating their parasympathetic nerves. So if you were a smoker, you might get a negative lip biopsy even if you have Sjogren's. So just be mindful of that.
Even 20 years later.
I don't know the length of how long the sustaining is, but it is
Yeah.
published. It is not just me making it
Wow,
up.
that's amazing.
Yeah.
You can
So
also get a false positive with smoking, which is weird too. I mean, but it can go both ways.
mhm.
Does Sjogren's affect cranial nerves as well as peripheral nerves, specifically the trigeminal and glossopharyngeal nerves?
Yes.
10% of Sjogren's patients will have trigeminal involvement. It can be one-sided or both-sided.
I had an extension of trigeminal into my ear. I lost my hearing in one ear. So I had to go on massive steroids, and I did recover like 90% of my hearing back.
I had
That's a really good point. Sensory neural hearing loss. That's a sudden onset of hearing loss.
Yeah.
It's an emergency. You got to get in
Yes.
and get on steroids. That
Yeah.
needs steroids.
Yeah, my ENT blew me off. So I put myself on steroids, 60 milligrams, the highest dose that you can take orally. I put it myself on it until I can get in with my neuro. I found a neuro ENT. He's like, thank goodness you had steroids, because you would have lost your hearing. And it's just sad that I can't even go back to that ENT ever again. It's crazy.
No. Mm-mm.
I had trigeminal ganglionitis, which was when it's just one trigeminal nerve. There's 3 branches of your trigeminal nerve. When it's just one branch that gets inflamed, we call it trigeminal neuralgia. But when it's all 3 branches, that's because the problem is in the ganglia, which is the root of the trigeminal nerve. So I had all 3 branches impacted by the Sjogren's, and I actually had your trigeminal nerve actually goes sort of into under your nose and into the tops of your teeth. You have like branches, your mandibular branch and your I get them backwards. But anyways, I actually had a tooth that turned gray. I was getting stabbing shooting pains into the tooth. And the dentist did some imaging, and actually I had vascular changes from the trigeminal stuff at that.
Wow.
It's fascinating. He saved the tooth because they put me on IVIG, so my tooth didn't fall out.
Like
But
Raynaud's of the tooth.
just like super, of all the weird, like really being frank, and I know we're on a webinar, but like weird shit, like it could be Sjogren's. So,
Yeah, that's
Yeah.
kind of how I look at it. Weird stuff, and then the steroids, unfortunate. But like I said, it's been about 3 years for me since I had to do anything crazy, emergency wise.
Yeah, I decided that Sjogren's should be renamed Everything Everywhere All at Once.
Oh, yeah.
my analogy is, remember if you're old enough to remember George Bush had the Leave No Child Behind like reading program.
Right.
And so I call Sjogren's the Leave No Organ Behind autoimmune program. Like it's a little this, a
Yeah.
little that. Everyone's coming along for the fun, all the inflammation. But anyways, I know we could probably talk for, maybe we should do another webinar just to do the Q&As, but
Yeah, there's a lot of
probably
questions.
let everybody go to sleep at some point. And but thank you both so much for joining me on this. I really
Thanks for having
enjoyed it,
me.
and I hope our guests, our audience members enjoyed the sort of casual banter we had in between questions. But
Thank you for your presentation. It was wonderful.
sure,
Yeah.
I really kind of ripped through everything because there's so much. So there's other videos on our autonomic disorders video library, which is vimeo.com/dysautonomia. We have a replication of that library on our YouTube channel. And so there's other Sjogren's lectures there that get more into the treatment and things like that. And I would definitely recommend the Sjogren's Advocate website and the Sjogren's Foundation website for more information. And you know,
And
there's
I have links to your stuff in the Sjogren's Advocate resources also. So if people are coming in through my channel, you can get into dysautonomia information like the Vimeo thing.
I also
Yeah.
want to give a shout out on, if you're on Twitter, follow Dr. Schaefer's on Twitter, but also Neuro Sjogren's. I don't know who this person is, but I think they have a great Twitter account, and
I'll tell her to contact you.
so there's, you know, patient advocate information that's very scientific and very helpful. And, you know, I do want to leave people with a sense of hope. They're actually, we have been in discussions with a pharma company that is interested in doing a new Sjogren's clinical trial on a new immunotherapy. So it's nothing announced, nothing public yet, but we're hopeful that will happen, and that will, you know, be one of many more steps that are needed to find more effective treatments for these patients. So
There's also
Yeah.
several systemic treatments in the pipeline that the Sjogren's Foundation has helped fund or help support these big pharma companies, which they have their pluses and their minuses, but we need new drugs. And two of them look quite helpful for fatigue. I mean, it's like, please just give it to me in my drinking water. So there's a lot coming down the pike. So we do have reason to be hopeful.
Absolutely.
all right. Well, thank you so much, everybody. And
Thank you,
thanks for everyone who
everybody.
stayed with us this whole time. And
Yeah, thank you.
apologies if
Thank
it's-
you. Have a good night.